to welcome you to this web session on the inclusion of reporting on the impacts of COVID-19 on health and health services in the Sendai Framework Monitoring in 2021. A very warm welcome to our country participants, to the coordinating institutions for Sendai Framework Monitoring, and also to the Ministry of Health focal points who are responsible for COVID-19 reporting at national level and to WHO, and as we will share with you in this particular session as part of the Sendai Framework Monitoring. This session and the working paper have been put together for you. The objectives of the session are to strengthen the engagement, the coordination and the interaction between the Sendai Framework coordinating institutions and also the Ministry of Health focal points in an effort to strengthen the coordination on the Sendai Framework reporting from a health sector perspective. We also wish to share the working paper on that you have received before, or you should have received by now, and that contains WHO and UNDRR recommendations on Sendai Framework reporting from a health perspective. And we also would like to share with you the opportunity, or give you the opportunity to be able to ask any questions or make any comments on the paper, and also what the speakers are going to share with you today. We have 3 presentations, and that first presentation will be an overview of the Sendai Framework Monitoring System to help frame the working paper. And then secondly, we'll have a presentation from WHO. We'll go into the details of the working paper to look at the specific indicators, the availability of data, and how WHO is receiving and reporting that data from member states. And then on top of that, we'll have a walkthrough on the screenshots of the Sendai Framework Monitoring System to really show you how the data will be entered into the system. I'd like to offer apologies for the short notice for this particular session, and also for the timing of the working paper being so close to the deadline or the milestone of the 31st of March. However, please note that this is a working paper. This is work in progress, and we would really appreciate all of your inputs, your contributions based on your experience and expertise to improving the paper and also strengthening the Sendai Framework Monitoring, not only for COVID-19, but for all types of events, and also with a view to a greater contribution from the Ministries of Health. There was another session this morning, so this is a repeat session, and we're looking at holding a session next week, most likely next Thursday afternoon, Central European time, as follow-up to this particular session. So this is a joint venture. It's another example of the collaboration between WHO and the UN Office for Disaster Risk Reduction, and not only in relation to strengthening Sendai Framework Monitoring and reporting, but also in disaster risk management in general, and specifically the integration of biological hazards and disease outbreaks in national disaster risk management strategies and managing the health and other risks associated with emergencies and disasters. And with that, I would like to welcome our colleagues from the UN Office for Disaster Risk Reduction in Bonn, Ms. Mira Markova and Mr. Rahul Sengupta, and say thank you very much to them for their collaboration in putting the working paper together, and also in terms of the organising this particular session. We're also joined by a very large team from WHO, colleagues from regional offices, from the Immunisation, Vaccines and Biologicals Department, the Health Information Management Department of the WHO Health Emergencies Program, and also colleagues from Disaster Risk Management and Resilience Unit, the Health Security Preparedness Department, and the WHO Health Emergencies Program. All of our colleagues are available to answer the questions that you may have today. I'd like to move on to some housekeeping or administrative matters. I'd like to inform you that this session is being recorded. As you know, we're using Microsoft Teams, and in this particular system, please use the chat for any comments or questions that you may have. We'll be monitoring those questions, and we'll do our best to answer as many of those questions as we possibly can. So why are we here? Well, the devastating impacts of COVID-19 on communities and countries around the world is reason enough for us all to work as hard as possible together to stop the pandemic, but not just the pandemic, to reduce the risks of emergencies and disasters that communities and countries face all over the world, and also the risks of future pandemics. As of 12:39 yesterday, Central European time, that's the 17th of March, there were 120,164,106 confirmed cases of COVID-19, including 2,660,422 deaths reported to WHO. These data and the specific numbers in the data are central to the purpose of this particular session and to the working paper. Essentially, WHO and UNDRR guidance in the working paper is encouraging and supporting and ensuring the consistency of the data that's being reported by member states to WHO with the data which member states and countries are going to be reporting to the Sendai Framework Monitor. While these devastating impacts have occurred, we've also seen high levels of collaboration between sectors in countries and between countries in order to save lives, manage health risks, and reduce the socio-economic impact. The WHO Director General, Dr. Tedros, echoed by the UN Secretary General, Mr. Guterres, and the Special Representative of the Secretary General for Disaster Risk Reduction, Ms. Mami Mitsutori, have emphasized the central values of global solidarity and national unity in overcoming the pandemic. We are all in this together, and this meeting is yet another example of existing collaboration that will need to be strengthened, not only to manage the COVID-19 pandemic, but also other emergencies and disasters, and also to strengthen the reporting in the Sendai Framework Monitoring System. So with that, I would like to invite our first speaker, Ms. Mira Markova, who holds the position of statistician at the UN Office for Disaster Risk Reduction in Bonn. And Mira is going to give us a presentation which will help frame the working paper and also provide some context for the reporting on COVID-19 in the Sendai Framework Monitoring System. So with that, over to you, Mira. Thank you.
Thank you very much, Jonathan, for this introduction, and a very good morning or good afternoon, depending on your time zone, to everyone who's been able to join us for this meeting this morning. So let me first start by sharing my slides with you. Hopefully you are able to see my slides. Can I get a quick confirmation?
Yes.
Okay, so indeed, as Jonathan introduced me, my name is Mira Markova. I'm with UNDRR's Bonn office, a statistician, and I'm going to take the next few minutes to talk to you about broadly what the Sendai Framework is, what the monitoring process entails, and what is the broad role of the health sector in that, as a basis for our further discussion later today. So the Sendai Framework for Disaster Risk Reduction was actually the first major agreement of the post-2015 development agenda, and it provides member states with the concrete actions to put in place to protect development gains against the risk and impact from disasters. So basically, it sets out the overall vision to reduce disaster risk, to address disaster loss across the globe, and it works hand in hand with the other 2030 agreements, most notably the Paris Agreement on Climate Change, and ultimately the Sustainable Development Goals of Agenda 2030. The Sendai Framework was endorsed by the UN General Assembly during the UN World Conference on Disaster Risk Reduction, a snapshot, a picture of which you're seeing on your screen now. And it was actually exactly 6 years ago today, on 18 March 2015. So basically today we're commemorating its 6th anniversary, in fact. So in a nutshell, the Sendai Framework, just to bring everybody on the same page, as in the audience, we do have people from health ministries who may not be well familiar. The Sendai Framework has a clear structure which is spread across its priorities of action, its guiding principles, and its global targets. And the overarching goal is to prevent new risk and to reduce existing risk of disasters. And this is through the implementation of integrated and inclusive measures across the economic, legal, health, cultural, environmental, technological, political, institutional domains, etc. So the key element here, the key element of the Sendai Framework structure are its 7 global targets, which are to be achieved by 2030. And the first 4 are centered around substantial reductions or decreases. So target A on decreasing mortality due to disasters, target B on reducing the number of affected people from disasters globally, target C on reducing economic loss as relation to GDP, target D on reducing damage to critical infrastructure and disruption of basic services. And the 3 remaining targets are focused on substantial increases. So target F sees the increase in the number of countries that have either national or local disaster risk reduction strategies, or both. Target F is talking about the increase in international cooperation for DRR to developing countries. And the last target G is foreseeing the increase of the availability and access to early warning systems for disaster prevention. So in order to measure global progress in achieving these targets, a set of 38 indicators were stipulated through an intergovernmental process. Namely, they came through as a result of the work of the open-ended intergovernmental expert working group on terminology and indicators for DRR. So this is how the 38 indicators for measuring Sendai Framework progress came into being through this consultative process. And strong accountability is one of the cornerstones of the Sendai Framework, and it is ensured by the means of the Sendai Framework online monitor. So this is UNDRR's web-based monitoring system where countries log in, report their progress on the various targets, and this is done through reporting official national data collated on an annual basis under the 38 indicators. And basically the Sendai Framework indicators are intended to be objective, comparable across countries and across time. And they aim to provide a measure of progress in achieving the global targets, but also revealing important trends in how we're doing on reducing risk and reducing losses. In line with the coherence between the frameworks of Sendai and the SDG of Agenda 2030, there are important synergies between the reporting under these two. So basically what we're saying is that the Sendai Framework indicators, almost all of them, in fact, 5 of the 7 targets indicators are completely equivalent to the SDG indicators under 3 main goals. So goal 1 on zero poverty, goal 11 on sustainable cities, goal 13 on climate action. So when countries log into the Sendai Framework Monitor and report losses under the various indicators, they're automatically also reporting under the SDG process. And for the moment, there are 195 UN member states and observer states that have access to the online monitoring system. So reporting is done by member states by designated Sendai Framework focal points on an annual basis. I should say actually rather on a continuous basis. And data can be entered at any time, at any point, for any indicator, for any year. But there are, however, 2 milestones every year when we take a snapshot of what is contained in the system. And then these serve as de facto deadlines. One is on the 31st of March. The other one is on the 30th of September every year. And the 30th of September deadline is used for internal UNDRR reporting, whereas the 31st of March milestone is, in fact, what has brought us all together today, since it is coming up very shortly, very soon. It's a very important one because this is the time when we compile the annual SDG reporting. So the data that's been reported in the Sendai Framework Monitor as of 31st of March this year for the year 2020 will be officially reported thereof to the high-level political forum of the SDGs and will be fed into the special report of the Secretary General on SDG implementation and the equivalent report on Sendai Framework implementation. And there are a few important aspects that we would like to highlight about the Sendai Framework Monitor at this point. So aspect number 1 is the option of countries to set up their custom indicators. In addition to the 38 existing indicators. This allows countries to expand the range and the depth of their reporting according to their national priorities. The other aspect that we highlight as a very important one is disaggregation. Though this is not obligatory, we do urge countries to report disaggregated and granular data as much as possible, so by age, by sex, by hazard, by geography, subsector, etc. Obviously, this depends on data availability. Data is not always there. So with this background, this is why we're holding the event today. Human health cuts across all the global frameworks, in fact, but it is explicitly included in the Sendai Framework for Disaster Risk Reduction. It includes epidemics and pandemics among the biological hazard that it very urgently pertains to. The framework recognizes that among the management of disasters and emergencies, the management of disease outbreaks and of pandemics and epidemics is a key priority for member states. And the Sendai Framework further recognizes that there's a strong connection between health and between disasters and does promote the concept of health resilience as an important pillar, as very central to DRR in general and to sustainable development. And there's quite a number of the indicators under the 7 targets that are directly related to health. in terms of reducing, first of all, disaster mortality due to disease outbreaks. That's under target A. Also, under target B, there's the indicators on reducing the number of people that are affected by disease outbreaks. And then there's also under target D, disaster damage to critical infrastructure, critical health infrastructure, and disruption of basic services such as health services. And the role of the health sector is also further acknowledged under target E on the development and adoption of disaster risk reduction strategies, which really need to cover the health sector in detail. So health is therefore a key theme throughout the Sendai Framework. When epidemics and pandemics strike, such as what we're living right now with COVID-19, it is very important to make the necessary reflections in the reporting cycle. But more on this will come very shortly from WHO colleagues. I will stop here on that topic. But what I would like to flag at this point is that in order for health-related data to be well reflected and well reported in the Sendai Framework monitoring process, there are a number of steps that can be followed and taken at national level. Option number one, which we can recommend, is that for a focal point from the Ministry of Health or from a relevant national health authority, which disposes of the relevant data, to be nominated, for such a focal point to be nominated, and to be connected to the Sendai Framework focal point that is acting in the country. And then that focal point from the health ministry side, or from the health sector side, can be given login credentials in the Sendai Framework online system, either as a contributor or a validator. And in that case, then the health sector representative can log in directly and provide data directly, making sure there's complete consistency between health sector data and the data that ends up being reported on the DRR side. An alternative approach is for the Ministry of Health to liaise directly with the Sendai Framework focal point and to provide the data through another channel, not directly in the monitor. So in either way, or in either option, it is important to think about and establish the necessary communication and information exchange channels in advance of the reporting milestones to the extent possible. And of course, the WHO and UNDRR are available to provide necessary support on this. So while I'm on the subject of the support, this is my last point that I'd like to make, that the WHO has developed the technical guidance notes on Sendai Framework reporting for ministries of health. And this document provides important information on key issues regarding data collection, methodologies, data exchange, etc. It's definitely worth checking out if you feel that you need support in the reporting this year. It's available online. We've provided the link in this presentation, which will be made available to you. And with this, I thank you very much and for your attention, and I hand it back to Jonathan for the next segment. Thank you very much.
Thank you very much, Mira, and also for taking the time to go through the Sendai Framework itself. Obviously, a very strong focus on public health there, and also to take us through the Sendai Framework monitoring system. Some of you are very familiar with the system, I'm sure, as members of the coordinating institutions. On the other hand, we have colleagues from the health sector who may be less familiar with what's in that Sendai Framework monitoring system. And it's really important that we're all on the same page. And as you said, to emphasize the communication that's needed between health sector and the coordinating institutions for Sendai Framework monitoring, such that the data that is entered can be aligned as best possible. So thank you very much, Mira. We'll now like to introduce the next speaker, and I have pleasure in introducing Dr. Ankur Rakesh, Ancor is a consultant with the Disaster Risk Management and Resilience Unit at WHO, and he's going to take us through into more of the technical details of the working paper to look at the indicators and also how that data is being shared and is available so that it can be consistently integrated into the Sendai Framework Monitoring System. So with that, I'd like to hand over to you, Ancor. Thank you.
Thank you, Jonathan. A very good day to everybody. Good morning, good afternoon, good evening, where you are joining from different parts of the world. So I'll just start sharing my presentation. Please give me a shout out if you don't see the full presentation. Okay. Jonathan, are you able to? Okay,
yes,
great.
that's good. Please proceed.
Okay, so good day, everybody. As Jonathan mentioned, the topic of my presentation today is inclusion of the impacts of the COVID-19 pandemic on health and health services in reporting for Sendai Framework Monitoring in 2021. Can you still see my slides? Can somebody confirm, please?
Yes.
Okay, thank you. So the presentation focus will be on the key points from the working paper to support the inclusion of reporting of the impacts of COVID-19 on health and health services in the Sendai Framework Monitoring System for 2021 reporting. As has been said by my colleagues, the 2021 Sendai Framework reporting reflects on the impacts and activities from 1st January to 31st December 2020. Here, I would like to highlight, before we go into the details of the working paper, I would like to highlight 3 important documents which are key for the health sector related to management of risk. Of course, there's the Sendai Framework for Disaster Risk Reduction, which puts health at the center of disaster risk reduction. And my colleagues from UNDRR have already set the scene for the overall Sendai Framework Monitoring System. The second one, which I mentioned here, is the International Health Regulations, which is an international agreement to limit and respond to the international spread of diseases like pandemic and has its own reporting mechanism. The third one is the Health Emergency and Disaster Risk Management Framework, which is to advise countries on the capacities required to manage the risk of all sorts of hazards, including pandemics, and acts as a bridge between the Sendai Framework, the international regulations, the Sustainable Development Goals, and the Paris Agreement. Am I audible to everybody? Just checking.
Please proceed.
Okay, sorry, I just heard some background noise. Sorry. Is the focus of this session is COVID-19 reporting. However, there is a wider context in terms of strengthening the health sector reporting for the Sendai Framework Monitoring System. In 2020, WHO published a WHO Technical Guidance Notes on Sendai Framework, reporting by the Ministries of Health to guide the health sector on their role in collecting and reporting data for the Sendai Framework. It exemplified that most of the global targets and indicators are relevant to public health, and some are specially focused on public health, namely the indicator A2, which focuses on mortality, the indicator B2, which is the people injured and ill, indicator D2, which talks about damage and destruction of health facilities, and the indicator D7, which talks about disruption to basic health services. Now, this applies to an all hazards approach in the scope of the Sendai framework, including disease outbreaks and pandemics. The key message is to encourage stronger coordination and engagement of the health sector in all aspects of. And this working paper with a focus on reporting on COVID-19, it yet another opportunity to facilitate that engagement of the health sector and strengthening and alignment of the health data in the Sendai framework monitoring. Secondly, you will note, and my colleague also highlighted this very nicely, there's a deliberate choice of the term working paper. Why this? This is to reflect that we expect the guidance to evolve, leading to the milestone for reporting in September this year. For the milestone of 31st March 2021, we have focused on 3 indicators in the paper, but we acknowledge that they do not cover the full extent of impacts of COVID-19 on health services, or other sectors. Therefore, we seek and encourage your feedback and ideas based upon your strong experience and expertise and how reporting on COVID-19 could be strengthened under the Sendai Framework Monitoring, linked to either the global targets and indicators or as a custom indicator. So, now we come to the actual working paper, and as advised, this is a working paper, and the target audience for this working paper are the users of the Sendai Framework Monitor, that is the coordinators, the contributors, the validators and observers, and official representatives or focal points of the national ministries of health or national health authorities. The objectives of the paper is around ensure alignment of national reporting for the Sendai framework and official reporting on COVID-19 by ministries of health. To enable coordination between the National Ministry of Health and the Sendai Framework Monitoring Coordinating Institutions in each country on Sendai framework reporting. To facilitate the use of the existing data on COVID-19 at country level for Sendai framework reporting, and to align the overall system guidance on Sendai framework reporting for COVID-19 with the WHO guidance on COVID-19 monitoring evaluation, initially, and the key frequency of reporting in the first instance itself. And for which data is already reported and published. The working paper contains advice related to 3 indicators, which are mentioned in the last bullet. And these are the ones which are of primary concern to public health in the context of COVID-19. These are the number of deaths, which is the indicator A2, the number of ill people, which is the indicator B2, and the third one, D7, which is about the disruption to health services. The paper focuses only on these indicators for which the data is already collected and reported by the Ministry of Health to the WHO. On the right side, you see the screenshot of the working paper, which you have received already. So going into the granularity of these indicators, the indicator A2, which is the first one to be reported. In the Sendai framework, the indicator A2 is the number of deaths attributed to disasters per 100,000 population. In the context of COVID-19, this is explained as the number of COVID-19 population. The number of deaths reported in the Sendai Framework Monitor against this indicator should be the same number of deaths that the Ministry of Health has reported to WHO in accordance with the national reporting of COVID-19 deaths with the cut-off date of 31st December, as we know. WHO has provided technical guidance on defining COVID-19 deaths when the deaths can be attributed to COVID-19 and not other causes, and references for this is provided with the paper. To repeat, and the most important point, the reporting of this data should be in accordance with the cases as determined and reported by the Ministries of Health to WHO. Additional information on disaggregation, for example, disaggregation by gender, disaggregation by age, may also be provided in the information box in the monitor, and my colleague will run through this monitor in the next part of the presentation. The next indicator is indicator B2. This in the Sendai framework is the number of injured or ill people attributed to disasters per 100,000 population. So in the context of COVID-19, this would become the number of cases of COVID-19 per 100,000 population. The number of cases reported in the Sendai Framework Monitor against this indicator should be the same number that the Ministry of Health is reporting to WHO on the number of cases as of the deadline of 31st December 2020. This will be in accordance with the national reporting of COVID-19 cases, and WHO has provided technical guidance to define a confirmed COVID-19 case based upon type of testing and or contact with other cases. The working paper again includes these references for detail. To repeat again, the most important point, the reporting of these data should be in accordance with the cases as determined and reported by the Ministries of Health to WHO. Again, it is important and useful if additional information on disaggregation, for example, disaggregation by gender and age, could be provided in the explanatory notes. Coming to the last indicator for this milestone, the D7 indicator. The Sendai Framework indicator is in the Sendai Framework. This is defined as the number of disruptions to health services attributed to disaster. Now, here we acknowledge that COVID-19 has caused widespread disruption to health services, and it is very challenging to collect that data on the number of disruptions attributable to COVID-19. So our recommendation around this is to adapt and use the indicator from the WHO Strategic Preparedness and Response Plan, Monitoring and Evaluation Framework, pillar number 9. And some of the ministries of health are already reporting these data to WHO, so the data is there. The indicator is defined as the percentage of countries where at least one vaccine preventable disease, VPD, immunization campaign was affected. That is, either it was suspended, postponed, in partial or in total because of COVID-19 related reasons. Countries are requested to report on the disruptions by COVID-19 to at least one VPD immunization campaign in the country. And additional information can be provided on the disruptions, disaggregations by the geographical unit in a country, again in the explanatory box. Also, there has been disruption to many other aspects of the society like education, which requires further explorations, and that would be taken up as part of the work in the next towards the next milestone, which is in September. So coming to the next slide, these are the following are the recommended steps for establishing the institutional arrangement for the health sector reporting on COVID-19 in the Sendai Framework Monitoring. First and foremost, identify the relevant Ministry of Health focal point for Sendai Framework Monitoring and reporting. For the purpose of COVID-19 reporting, this could be the National IHR focal point, the International Health Regulations focal point, or the Director General of Health Services. Second, establish the engagement between the Sendai Framework Monitoring Coordinator and the identified Ministry of Health focal point. Then agree on methods and plans for Sendai Framework reporting by the health sector to comply with the national and international timetables for reporting. And the I think my colleague Meera also referred to it. The coordinators are recommended to register the officials from the Ministry of Health or national health authorities as a contributor and validator in the Sendai Framework Monitor. Then the Ministry of Health can directly enter and validate the official data for the relevant indicators, which makes it easier. Otherwise, some other agreement will need to be made. Finally, we would like to request the Ministry of Health focal point to share the report with the respective WHO country office or the regional office. Coming to the last slide of my presentation, in conclusion, we would like to reiterate the key message. There is a need for an effective coordination between the Sendai Framework Monitoring coordinating institutions and the Ministry of Health, who have the responsibility for health sector reporting on COVID-19. The data reporting in the Sendai Framework Monitor on COVID-19 should be aligned with the official Ministry of Health reporting on COVID-19 that is already published by WHO. Make use of the available and official data sources. The Ministry of Focal Points data could provide data for COVID-19 reporting to. And I would like to close by mentioning that data and reporting are core to support evidence-based decisions and risk management actions. So that's the conclusion of my presentation. And the last slide is about references, which have been used and also present in the paper. And you can go into paper. And I look forward to your comments and any questions. We'll answer the questions at the end. Without further ado, over to you, Jonathan.
Thank you very much, Ankur. That's very helpful indeed. You've really highlighted where the working paper focuses on those three indicators, and also a reflection that we know very well that those three indicators do not represent the comprehensive range of impacts that the COVID-19 pandemic has had on society in general, let alone health and health services. And so we've got some extra work to be done over the course of the next six months or so, working with you all on strengthening the paper and also on how COVID-19 reporting can be strengthened in general. So thank you very much, Encore. And let's now go to my colleague from UN Office for Disaster Risk Reduction, Mr. Rahul Sengupta. And Rahul will take us through some of the screenshots for the Sendai Framework Monitoring System itself. So over to you, Rahul. Thank you very much.
Thank you again, Jonathan. So as Jonathan said, so my job is actually to run you through, to distill all that information that you have got in terms of the roles that the different institutions can play in the Sendai Framework monitoring process, in terms of the indicators that have come in are going to be relevant and where the data is going to be sourced. So this, in the background of the information that you have received now, this is where the rubber hits the road. This is where most of you who have used the system are aware of how it works. But what we will really go into now is precisely where the COVID-19 data is being entered and is to be entered, and how that data will be used for some of the specific, let's say, compound indicators or further calculations that will help us to do better analysis. So as most of you are aware, this is just to mention, I'm doing this on a training site, which means it's so any country that you see here, it's just all the data is a dummy data. So just so that it won't be any data. We are not overwriting any data from the countries. So to start with, this is our homepage. Oh, I'm sorry, I just got logged out right at the. Okay, so this is our homepage. We start with, you have to give me 1 minute, please. I just got logged out. I'm sorry for that. Yeah, we are back. So this is our homepage from where we start by, so this is where we start entering the data in terms of, as you can see on the left, targets A, B, C, D. The first, as we talked about, was targets about the number of deaths. That is our indicator on number of deaths, which is indicator A2. But before we do that, we need COVID-19 itself as a hazard against which we can enter the data. Hence, for that, we have to start with the setup. So we go back first and work on the setup. First is what we mentioned, that some of the institutions that, the institutions of the ministries of health, the department or the Directorate General of Health and others who could provide the data could be actually brought in as the responsible responsible contributor, which would enable them to directly enter the data. For that, we as SFM focal points know and coordinators know, the idea is to bring in and specifically provide that access to those departments and ministries. And as the coordinators would know, and this is again a test, as you can see, because it's on the training side. So here, for example, if we have the A2, we can make one of the contributors as ministries, or one of the contributors as Ministry of Health. So that would help that focal point in the Ministry of Health could actually provide the data directly. However, that's not the only way to provide the data. The Ministry of Health can also offline provide the data to the Sendai Framework focal point institution, who would eventually then enter the data on their behalf. But as our colleague Jonathan and Ankur mentioned, it's most critical to have a total consistency within the data that comes from the Ministry of Health and what is eventually being entered into the Sendai Framework Monitor. So that's the first thing I wanted to mention, is that if possible, or ideally speaking, it's recommended that we bring in the Ministries of Health, the focal points of Ministries of Health, the Department Director General of Health, to be into the system as a contributor who can provide the data directly. So next is, as I mentioned, to actually add the COVID-19 as a hazard, because we are looking at data, we are looking at really hazard disaggregated data when we are talking about COVID-19. So as you will see in the list of pre-filled hazards, we have actually added now COVID-19 in that list. So when you click on this and you do done, what happens here is everywhere in the system, wherever there is an hazard disaggregation, COVID-19 gets added there. So let's go back and see how it affects the target an indicator A2.
Excuse me, Rahul. Excuse me, Rahul.
Yes, please.
May I stop you there?
Please.
What we see is that we have your presentation against your name, but not in the main window of the session. So could you try to put that into the main window?
Okay, I'll because it was showing. I'll stop for a minute. I'll just stop sharing and reshare again. Huh?
Okay, I'm sorry to interrupt. This is Sarah from UNDRR, but if you're having trouble seeing, if you click on Rahul's name from the participant list, the small icon, it should switch. And there he tries again.
Do you see it now?
Yes, thank you.
Is it better now?
Thank you.
Yes.
Thank you so much, Sarah.
Thanks a lot, Sarah. Back to you, Rahul. Please continue. And
if
you feel the need that you need to go back one slide.
Okay, sure. Sure, I'm happy to do that. So let me go back to the slide about the disaggregation. Will that be okay?
Yes, please.
Yeah. So what I was saying was, so let me just take that COVID-19 off and just show that again. So the idea is now on all your list of hazards, there would be others like earthquakes and cyclones, but COVID-19 won't be there. So our first request is to the coordinators of SFM to select COVID-19, which we have especially added into the list of available hazards, and include that here. What it does, as you know, would be that everywhere, wherever the hazard disaggregation is available as for data entry, COVID-19 gets automatically added. So let us see how that affects our reporting. Let's start with where we went back to target A, indicator A2, which is the first indicator where we are looking at COVID-19 reporting. What we've also done.
Excuse me.
Yes.
Yes, it's a question from Jordan. Did you add COVID-19 in the disaggregation? Because you couldn't see it in from our system.
No, so yes, so that's what I'm saying. I'm just showing this to you right now on the training site. We will it's going to be done from today, but it's just this is just to demo. This is a demo for now.
Okay, thank you.
So because we got the guidelines finalized yesterday, so we got it on the demo, and we will put it today itself. You will see it everywhere. But it's a very important question. I should clarify that. Yes. So right now it's on the demo site, and by today it will be on our all production site as well.
Okay, thanks.
Thank you very much. So on the indicator A2, you will see that we had also earlier a box talking about the lost database, that it's right now, there is no direct transfer of data on the lost database. In that same box, you will find in bold this information about COVID-19. So what happened? This is one way of, as a reminder, we are putting it there so that, when colleagues are entering data, they will be reminded that, okay, this indicator needs COVID-19 disaggregation wherever possible. So going into now A2A, which is where the actual data entry happens. As you can see, if you go into hazards, now you will get COVID-19. Earlier, you had only earthquake and cyclone, and now when you added COVID-19, it's been entered here. So here, let's say you put number of deaths as 100, yeah? And that gets saved. Oh, that should get saved. Is always, but yeah, okay. So that data gets saved. So also, of course, remember that disaggregation is only a number that you are providing additionally. You do have to provide the total number of deaths as well, of course. So which mean if you have deaths from other hazards at say 800, then with including COVID-19, it would become. I mean, you can just put just for But what I'm saying is you will not, the numbers will not get added automatically. Okay, it's saved. So the numbers don't get added automatically. So once you have the disaggregation, you put in the total there, which is in here, the total will be 600. So for 2020, the total comes to 600. And the disaggregation, as you can see, is COVID-19 100, earthquakes 200, tropical cyclone 300. So that's the first thing. Now, the next thing that you will see on in the paper that has been circulated is how can we get disaggregation of the COVID-19 deaths themselves. Now, as you know, in the system, it's not possible to do double disaggregation, meaning you cannot have a number of deaths from a hazard, let's say earthquake, and also provide the number of males and females deaths from that. We can only do disaggregation at the total losses. So all the disaggregation available here in terms of geography, sex, age, income, disability are related to the total disaggregation. However, this is a special case. We really want to see as much information as possible. So we would request is that you take advantage of this new feature that we have called additional information. When you click on additional information, and all this is mentioned in the paper also, and in this box that I showed you, this box will open up. What you can do there is just put male, whatever the number, let's say 40, and then female, let's say it's 60. So what happens then is we get this number, these numbers, at least in this box. So you see there's an explanation available. This breakdown comes at, okay, you can just mention, sorry, maybe you should mention above COVID-19, just so we are clear. So from COVID-19, we have male and female breakdown. As also mentioned in the paper, of course, this is an additional information, which means that the system will not automatically calculate, do analysis on this breakdown. However, we will take the initiative. We are taking the initiative of doing analysis that we get on disaggregated data offline separately. So only thing you'll have to bear with us is that this won't be available real time online, like in the analytics, but we will definitely do an analysis that will be available through the data here offline, directly, and then in the reports wherever possible, those analysis will go in. So that's how we envisage. And this is just not for male and female. This is not for only sex disaggregation. The same thing can be done for age, income, disability, and also geography. There is, as just one more point to emphasize, is that there's a character limit of 1500 characters here. So maybe there would, if you have a lot of information, especially on geographical breakdown, what we would suggest is if you could have that information online somewhere and that link could be provided. But otherwise, the other disaggregations, I don't think would need too much text, and they can be easily put into this explanatory text. So I hope this one is clear. So just to repeat and clarify, so the data on COVID-19 numbers go in here. Of course, that goes into the overall number of deaths under in here. And in addition to that, we are requesting for disaggregate data as much as possible. But because we don't have double disaggregation, we are encouraging colleagues to use the explanatory text box which you can click from this small gray tab or gray button here. That's for A2. Now let's go to the next one. It's very similar, which is the B2, which we talked about. My colleague Rakesh mentioned. It's the same thing. Again, we have COVID-19 as a hazard. You can put in the numbers here, and then you can put in a total number that is relevant for in this case. The same thing applies for disaggregation. I'm not going to the details here. Again, it's the same explanatory box. We encourage you to use the same one to provide the same disaggregations as is used here. And you can see, for example, if you want to do age-related disaggregation, the 3 age period years that are mentioned here, adults, children, and seniors, we would request you to follow the same age groups and provide us the data in that additional explanatory text box. The rest, everything remains the same. If there are a larger number of information in terms of the geographical breakdown, we would request you to have it online somewhere and then link it here and provide the link here so that we can do the analysis offline. So, so just to again reiterate, the data on COVID-19 goes in under hazards, COVID-19, which feeds into the overall number of affected people or ill people into the A2A figure. The disaggregation goes into the additional information, explanatory text, and that is true for all types of disaggregation: age, sex, disability, income, or geographical area. And then again, we will use the same data offline to do the analysis for disaggregation. Now, moving quickly on to the next one, which is the last one, the D7, which again, our colleague explained in the previous presentation. So here, the main difference is that we are not looking at, human disaggregation. The logic remains the same. We have the figures for COVID-19 here, and we have the total number of disruptions. So as mentioned here again in the box, you will be reminded how that COVID-19 disruption to health services is defined. It is defined as a country is requested to report if at least one vaccine preventable disease, VPD, immunization campaign was affected. It is either suspended or postponed or partially or fully. So this is what WHO prescribes as being, recommended definition for calculating or asserting the disruption of health services. The vaccine preventable health immunization campaign is going to be the specific area which will be accepted for calculations of prevention of health services. So with that, you put in the number here. We can put in, actually speaking here, it would be mostly one, because that's the, as it says, at least one. If you have in one place and a disruption of that campaign, you put in one, and here as well, it will go in with the number of other cases of other hazards. The reason is that even if you have, say, for example, here also you can provide the geographical breakdown. That's the only one you can provide because, as I said, the human-related disaggregation is not available in this one. So even if you have multiple, say, states or districts or provinces having the campaign disrupted, the criterion we are using is at least one of the campaign is in place. So whether it's one or multiple campaigns, we will consider it as a country that is marked as having a disruption of health services. What that helps is, where that helps is, or where that feeds into is what, as mentioned in the previous presentation, there's a specific indicator being created for this particular health services as WHO requires, and that is the percentage of countries who have their health services disrupted. So which is where, so as you see here, the D7 is the number of disruptions. So when a country reports that, yes, we've had a disruption of the health services as defined by the vaccine preventable disease campaign, effect on that, that country gets recorded as one of the countries with that disruption, and so a percentage of a global percentage will be calculated on that basis offline. So that is very important for us to understand in this particular D7. It is just not your data that comes in terms of the disruption that has happened in the country, but also WHO will look into a percentage of the countries that have the disruption, which is as per their monitoring and evaluation framework. So I will just to close and to reiterate, we have the number provided here for COVID-19. If even one campaign is suspended or partially disrupted, the country marks as one, means they have one disruption of health services from COVID. That same number gets added onto the total number of disruptions, and in the additional information box, you can provide for example, the geographical breakdown, if you have, of where all the disruption of the campaigns happened. But irrespective of the number of geographical units, since it is defined as at least one campaign disrupted, the country will be can mark itself as having the health services disrupted. So I hope that would be clear. If there is any question, we're very happy to receive them here, but also we'll be available if you send us emails on this, and we can provide you specifics. As you can see, you can follow the paper there. We've put it onto the system here in the same page. It's specifically where the data entry is going to happen, and of course, we are available for any support thereafter.
Thank you, Rahul. That was very practical and showing exactly how that data needs to be entered into the Sendai Framework Monitoring System. Thank you very much. And for, like I said, many of you will be familiar with that system, but others not so. Now, we're still looking for questions. I think we've got a couple that have come in. And I'd also like to reflect on the fact that we had some questions this morning which were very helpful in terms of giving the opportunity for some of our subject matter experts, technical specialists and resource people to actually respond to those particular questions. So in this regard, I'd like to give the floor to my colleague, Dr. Boris Pavlin, who will give us some further explanation in terms of the type of data that WHO is receiving from member states, the availability and access to that data, and really some of the challenges associated either with collecting and reporting that data. So over to you, Boris. Thank you very much.
Thanks a lot. Please jump in anytime if you feel like I've missed a point, because I've already gone through this earlier today, and I won't remember what I've said and what I haven't said. So I need to share my screen again. Who's gonna action that? Okay. In the meantime, basically, we are collecting cases and deaths from member states through a variety of mechanisms. Okay, great. No, that's not it. Sorry. Okay. So there are basically three major mechanisms through which we collect data. The first is the case-based reporting, cases and deaths. This is the left thing, daily aggregate data. Can you see my screen? No, hold on. Sorry for the technical problems here. I'm going to try this again. Okay. Can people see a slide that says COVID surveillance data?
Not yet.
Okay. Okay, one last try, and then I can just improvise it and put it in the chat. Okay, I hope you can see this now.
Correct.
Okay, so on the left-hand side, you have daily aggregated data, and this is basically every day we get the total cases and deaths from every country in the world and territories and so on. And this comes to us from a variety of mechanisms. They're all official data, but they are delivered through many different mechanisms. In some cases, this is countries' electronic reporting systems that we tap into, such as for the European region, the ECDC, the European Commission countries. And for others, it's taking the data directly from official websites by our ministries by our regional offices, and then we pool them at headquarters. In some cases, it's Twitter feeds and other things, but all official sources. I would explain that, first of all, this is just cases and deaths. Further, I would explain that, no system is perfect, and that whatever they report as their cases and deaths, we need to just take it at face value, even though we realize our limitations. So on the cases side, first of all, we have a number of, lots of people are going to have COVID and not even present to healthcare and therefore not even be identified. Then in general, the definition of what constitutes a case, we have indicated that it should be a laboratory confirmed case, initially PCR, and then later we've added certain ways in which rapid diagnostic tests can also lead to confirmation. Most countries have followed suit, but some countries also include probable cases in their reporting, so that there's no way to be 100% consistent. But that's okay for this exercise. It's as good as one can reasonably get. And it's also important to recognize that, yes, there are, technically the definition in the Sendai framework is of illness, and an asymptomatic infection could arguably not be considered an illness. Some asymptomatic cases are included in the confirmed cases, but for the most part, the ones that are being identified are those that have symptoms that are presenting to healthcare, and the asymptomatic cases are relatively few in the counts, even though maybe asymptomatic cases make up about a quarter of all cases. In most surveillance systems, the only time those are picked up is when they're associated with contacts of known other cases that are undergoing contact tracing and testing. So they may, in general, it's a reasonably close approximation to ill cases. You have similar issues with deaths. We have patients who are, who die but aren't recorded as COVID, may not make it into the counts. On occasion, you may find a person who had COVID. Our definition for death, for a COVID death, is anyone who had COVID and they died during the acute phase of their illness. Unless it's something obvious like trauma that was the cause of death. So, there may be a few in there that are not actually the cause of death wasn't COVID. They would have died anyway, but in most cases, it's as good as we have. There's also a limitation for confirmed COVID in that some countries with low lab testing capacity have to prioritize, have had to, and continue in some cases to have to prioritize testing for severely ill persons. There's nothing really we can do about that for these purposes. Now, those data are not disaggregated in any way. Now, we have another system, which is detailed surveillance data, which comes through two different pipelines. One is case report forms on individual patients. We have about 50 million of those in the WHO system. And I'll show you, well, I guess I don't really need to. This part down here is an example of an age-sex pyramid from case-based data. We're summing up the individual patient records for these people, and this can be disaggregated down to the country level, with the exception of a small number of countries that have chosen not to allow that disaggregation to country level, and also noting that only about 2/3 of all countries have contributed any case-based data, and virtually no countries have contributed all of their cases into the case-based data system, such that it's important that if you do rely on these data for disaggregation of, for example, age and gender, you note that it's on a subset of cases and that there may be some biases there. We have a similar system set up where to alleviate the burden on countries from doing case-based reporting, we decided to capture the most important indicators from our perspective in an aggregate reporting system that they only have to do once a week, where we still get age, gender or sex, healthcare worker status, number of cases, deaths, and hospitalization, and testing rates. We don't get, for example, two of the disaggregation dimensions that you're interested in, which is, for example, income and disability. Those are simply not available in either the case-based or the weekly aggregate data forms. The other thing is the weekly aggregate reporting is only available for 3 regions, CRO, WIPRO, and Euro so far. We hope it will improve. In our dashboard, which I'll drop the link into, so this is the global dashboard, covid19.who.int. The middle 2 boxes here are both on a dashboard that I'll drop the link to in the chat. And just so you're aware, when you pick a country, you don't have to choose which source of data is the better source. It automatically chooses the best source of data for the disaggregations you want. And if your country has chosen not to allow that disaggregation, the name simply won't exist in the drop-down list. I would say there are, for the other disaggregation, first of all, if a country, if it's something like age and sex where we show disaggregation, but for your country it's not available, and also for the indicators for which we don't collect the data, it's not to say that the countries don't have it, it simply means we don't have it. So that's when liaising with Ministry of Health counterparts, it's important to inquire, if interested, whether they do have additional data on other dimensions of disaggregation that you're interested in, because we don't have it, but they may. Finally, the one other thing I wanted to draw attention to is it was mentioned that it's important that the Ministry of Health data are consistent with published data. So the data that go into the Sendai report are the same as the data that have been made publicly available through WHO or through the ministry in the first instance. And I just want to draw your attention to one limitation of data collection, which is universal, that we have, when the data come from a country, if you were to go to their website on December 31st of 2020, it would have a certain number of cases. And these are cases by date of report. We don't have the date of onset for most cases, and it's not generally reported anywhere. When you go by date of report at the country level, you may get one number. That number may not be reflected in a regional dashboard or the global dashboard until 1 or 2 days later, because of a validation process. It doesn't mean that there's one or another of the data are wrong, but it explains why, for example, these cutoff dates, if we collect all the data as of midnight Central European time, and different countries are in different time zones and they cut off their data at different times, we're always going to be a little bit off. And this is why, for example, certain dashboards like Johns Hopkins University in the US will have a slightly different case count for a given country or global case count than us at any given moment in time. There is no universal truth here, but it's just something to be aware of. And we intend to have a disclaimer in the report that explains this discrepancy, but it's not worth losing sleep over, because it's just an artifact of how surveillance happens. With that, I think I will just hand it back. I'll drop the links in the chat, and if my colleagues from WHO can remind me if I've missed anything, and then I can touch on those, or if there are any questions. Thanks. Over.
Yes, thanks very much, Boris. That's really very helpful. I think you've explained how WHO, what is the data that WHO receives and reports, and you also make an important point that that doesn't represent the totality of the data that member states or countries have, ministries of health have, and so that's really important that engagement, that communication happens between the Sendai Framework coordinating institutions and the ministries of health, to really have a dialogue about the data that the Ministry of Health or the health authorities have, and how that can help the Sendai Framework reporting. And I think that's what we really want to encourage here in this session and through the working paper itself, and to see that relationship evolve over time, because the COVID-19 does provide a great accelerator, as we've seen in many other things around COVID-19, and particularly around data and reporting and so forth. So this is just another example of using COVID-19 as a springboard for advancing a lot of other work, in particularly around the Sendai Framework monitoring as well. So thanks very much, Boris. We had a couple of other questions, and some of them relate to those that have come in from Jennifer and from Alex Camacho. So I'd like to invite my colleague Taylor Warren to share some more information about the indicator D7 on disruptions to vaccine preventable disease campaigns, and also to touch on the broader issue of disruption to health services. That's a question that's really come through from Alex and Jennifer. So over to you, Taylor. Thank you very much. Maybe a few minutes on that would be great. Thank you.
Sure, and thank you for including me in this meeting, and then also thanks again for the questions. Indeed, I think for COVID-19 and this massive emergency response effort, it's really included disruptions for essential health services. So it's not just focusing on the response, but looking at the effect the response has on what the continuity of care of other health services besides COVID, and I think that that's been a strength of the planning as well as the reporting. So for this one, in 2020, WHO with member states had a global MNE framework that touched on the disruption of essential health services, and there were some of those tracer indicators, because it's very difficult to characterize the total effect of disruption of essential health services within a country without being collecting lots and lots of points of data. So one of those was the VPD campaigns, and it was looking primarily in humanitarian response and humanitarian context, and then looking at the planned vaccine preventable disease campaigns, and then looking at the disruption, whether they were postponed or canceled due to COVID-19, and that was due to mass gathering. So this is something that we traced this year with member states. The other things that were characterized were the overall yes, no, was it the vaccine was essential health services affected, and this is something that is being built in this year as well. And there was one last year, is the pulse survey. So WHO is administering a pulse survey, and it is indeed exactly what it sounds like. It measures the pulse within the country, within the member state, of what has been disrupted and going through different types of essential health services. And so that this has been very helpful, and it was administered, and there was a short report published in August, and then another one where the member states, it's being administered through regional offices as well as headquarters now, to be able to just start to characterize the types of services that have been disrupted overall within the system. So again, I think that this is something that is worthwhile exploring more. And I think because this is a working paper, it's good to understand what is possible, feasible to be able to report on this disruption and explore potential tracer indicators. Because I think if you're going to be able to encompass all, it's a little bit difficult. And some of those could be a disruption to routine immunizations of what the targets were at the beginning of 2020 versus what was realized. So you can be able to see kind of the disruption of routine immunizations for children under the age of 5. Excess mortality of non-COVID causes, to try to really get into this effect of the mortality. And then, as was mentioned by Jennifer, was the bed occupancy and different medical services. So I think the opportunity here is to really look together and think about what could go in the working paper for as this evolves. So hopefully this helps answer things, and I can also be able to put in just the old 2020 M&E framework from WHO, and it's a similar issue as what Boris was saying, that this is what was collected and available from WHO, but obviously there's more information at the country level, and will be good to work together as this this working paper evolves over time to be able to get to characterize more on the disruption of essential health services during the time of COVID. Thank you. Back to you, Jonathan.
Yeah, thank you very much, Taylor. And that just reinforces the point of the working paper, and really welcoming the inputs from all of you in terms of, well, how can we better measure the impacts of COVID-19 on health and health services? We would really appreciate understanding how that's being captured in your countries or at subnational level, and how can we reflect that in the approach to Sendai Framework Monitoring. I'm not just talking about the global targets and indicators, but there's also the ability to look into more qualitative approaches, as we've heard from Rahul, and also to look at custom indicators as well, so that we just need to ensure that the recommendations that are coming from WHO and UNDRR are in the spirit also of the global targets and indicators, but there are other ways in which those impacts can be collected, they can be reported, and of course we know that we should not limit this to health and health services as well. So we've also had a couple of other questions that have come in, and they also say, what are we going to do within WHO and the UN Office for Disaster Risk Reduction to further encourage the collaboration between the Ministries of Health or health representatives and the Sendai Framework Monitoring coordinating institutions, and how we're going to get the information out to our respective focal points. So I might just ask Rahul how that would be done within the UNDRR system, the SFM system, and then I would ask my colleague Adrian Rashford from the WHO Office for Europe to talk about how that information is shared within WHO. So first to you, Rahul. Thank you.
Thank you so much, Jonathan. So actually, I think since last week, the different regional offices of UNDRR have started communicating with the country focal points regarding what is coming up and regarding this paper, and they were eagerly waiting for it. And as of yesterday, this has been circulated with the country focal points. And so not only this, we are having this for session today, this morning, CET, again this afternoon, we'll have one for the other part of the world. We are also proposing another meeting next week. We will shortly confirm on that. A similar one session looking at going into further questions that may come up, and also for countries who may not have been able to join this due to the short notice. Also, we would, and then as you could see on the screen itself, what we showed that, we are putting in reminders in the system itself. So for the contributors, for those who actually enter data, it will come up on their screen, showing precisely which data is required and requested for. And as you will hear shortly, how WHO is also reaching out to the Ministries of Health and other national authorities of health to share the data with the focal points in the Sendai Framework Monitoring, which so basically it's a parallel communication going on. And one important thing we wanted to clarify here, we wouldn't want you to see this only for this short time frame for the 31st March milestone. Yes, it is important. We will take whatever data possible. We will also, of course, use WHO data that's available with WHO to do the basic reporting. However, country by country data for SDG reporting does not end with the 31st March. Till the next 30th September milestone, that will be, again, as you have seen in previous note verbals from us, it's an open-ended reporting system. So countries will continue to report. So we are actually looking very forward to have further consultation on the paper, as Jonathan mentioned, to look at not only these indicators, but also probably some of the other indicators which are impacted by the pandemic, and see how we can improve the reporting system. So we are actually hoping what we will get is on 31st March is just first snapshot. We would actually get much more information. Countries will be able to provide much information and diverse information. So probably even more on the other, not more, but also on other indicators by the 30th of September. So that would be very helpful. So I would say we should just look at this as the start of the conversation that we are having now. And over this time, we will provide more opportunities for this consultation. And as you know, the reporting for 2020 is not only 31st March, but also 30th September, but also beyond, because retroactively data can obviously be provided. But what is important is to have this common understanding, to understand the sources, the official data that would be there, which would make it very consistent between what WHO is receiving and reporting on its online platforms and official platforms, and what is reported on SFM. I'll stop here. Thank you so much, Jonathan.
Adrian, from the WHO Regional Office perspective, would appreciate your views on the process by which information can be shared through to member states. Thank you.
Thanks, Jonathan. So in general, the information that we have on Sendai Framework reporting would normally go through our country offices to be shared with the Ministry of Health counterparts. And the country officers would be very much made aware of what the requirements are, so they can support the ministry in pulling together these information, the data that's required, and engaging with the Sendai Framework Monitoring focal points at country level to be able to input that data. At the same time, through our geographically dispersed Office for Preparedness for Humanitarian and Health Emergencies, commonly known as our GDO, in Istanbul, we will be providing training to Ministry of Health counterparts on the requirements for Sendai Framework monitoring and the mechanisms by which specific data can be collected, as well as the hazards to be identified to be incorporated into the Sendai Framework Monitor will be determined, and then the information needs in relation to those. So we have a two-prong approach, one through our country offices to support the ministries in pulling these information together, and then the other through a series of training courses. So I think one of the things that we will be looking at is very much the indicator on D7, because as you may be aware, WHO has been running what we call the Pulse survey, which has really been looking at disruptions to a huge range of essential health services and due to the impact of COVID. So there is quite a significant volume of information there in terms of the scope of disruption to health services that I think we need to be clarifying a little bit in terms of how we enter those data. So back to you, Jonathan.
I would like to give the floor to Alex Camacho. Alex is a regional advisor on disaster risk reduction in the Pan American Health Organization, the WHO Office for the Americas region. And one of the questions that we had this morning, Alex, pertained to how the WHO regional offices communicating with countries, with member states around Sendai Framework Monitoring? And how could you expect, say, the PAHO office to be able to roll out this type of guidance, and what sort of mechanisms exist for this feedback between member states and countries and WHO and UNDRR? Thanks very much, Alex.
Thank you, Jonathan. Thank you so much, and thanks to all the speakers that have shared with us this valuable information. First of all, I want to thank you to UNDRR and WHO for responding so quickly and effectively to the queries that we have gotten from the countries. It started several weeks ago from specifically from a query that our colleagues from the Minister of Health of Chile, specifically from the Emergency Department Office, Paola Pontoni, who is the chief of that office, asked us how can they specifically better report the indicators are related to health, specifically the indicator D7 that was the query that Jennifer and I had previously. And as you said, this is a process that we need to strengthen, and this is a process that we need to also, just, can you give me a second, please? And this is a process that we need to strengthen in the upcoming weeks. So, as you know, we are implementing the Plan of Action for Disaster Risk Reduction. That is, it's aligned to the Sendai Framework, the 4 priorities, and we have permanently contact with the national focal points and the Ministry of Health. So, as we discussed it previously, Jonathan, and thanks for giving us the opportunity of translating the guidance. The WHO guidance. We are expected to have this guidance ready in a couple of weeks. And we would like also, as discussed previously with the UNDRR Office of the America, to roll out a series of meetings that not only will give us the opportunity to share this information with our counterparts, but also to have a discussion on these aspects that have been presented, that you have presented today. So that will be the channel. We have a permanent channel and a permanent communication with the focal points of the implementation of the Plan of Action for Disaster Reduction, and usually they are the same persons that are contributing to reporting to the national office. And I think that we are feeling a very important aspect that now the countries are aware that this information is coming. I see some participants from the Americas as well, and thank you for them to participate despite of the short time notice. But be sure that we will also expand this information to all of the countries. I see some colleagues from the Caribbean as well that are participating today, and thank you so much for that. So this is part of a process. We already have responses from the implementation of the Plan of Action, from, let's say, from the Sendai Framework Plan of Action in the health sector in the Americas. We have already 70% of the responses. We are now sending them the country profiles. And also this is part of this process that we have begun in 2015 after the release of the Sendai Framework. So that's anything from our side, and thank you so much, Jonathan, for responding so quickly, and Raul as well, and all the colleagues from UNDRR. Thank you so much.
You know, that's really helpful. Thanks a lot, Alex. And it's just testimony to the collaboration that we see between ministries of health and other actors in the disaster risk management community, which has only been accelerated during the COVID-19 times, and we would like to build and reinforce that as we go forward. There's lots of benefits for all types of risks, and not just for the current pandemic, but for other disease outbreaks, this whole of society approach, which is really so very important. And also, as we've said before, with the Sendai Framework Monitoring and Reporting. I feel that we've taken quite a conservative approach with the working paper. We've focused on the data which is already being reported to WHO and those indicators. We didn't want to get ahead of ourselves in terms of the consultation that's necessary, so that the advice that WHO and UNDRR gives out has gone through a more extensive consultation process. And I think that's very important, because we'd rather give you the right advice rather than any advice. And so that means that we can ensure that what we're giving you is really the best quality, high standard advice based on the expertise of really the community with which we're working, which includes all of you as well, because we do need to look at issues like coverage and feasibilities and the practicality, etc. And we would like as much as possible to make that as usable by all countries as well. And like I said, there are flexibilities within the system which will allow us to improve this reporting going forward. I'd just like to give Rahul the floor for 1 minute or so. He's got a comment that he would like to make, and then come back to me and I'll close the session. So Rahul, back to you.
Thank you so much, Jonathan. I just wanted to echo what you and colleagues from WHO have said. Just from a personal note, I can say 2 years back, when WHO invited me for their consultation on the technical guidance for the Sendai Framework Monitoring System for Ministries of Health, we were very happy. We were really very happy. And I remember met Alex in Geneva, and we were like, great, this is what WHO is doing. But then, come 2020, this is amazing. This was really foresight. I mean, this is an amazing foresight, because we think of, oh, we know we've covered all hazards, and then suddenly a tsunami comes and we don't know what to do. Then again, we are always thinking, okay, we know everything we are covering, but then suddenly a pandemic comes, and then we again work on those specifics. But really, WHO deserves a lot of credit for that. I think 3 years ago they started working on this monitoring systems for on disaster risk, and this is in addition to all the disaster risk management frameworks that they already have. But this was very focused on how the monitoring for Sendai framework was being monitored. So really kudos to colleagues Kutsia, Jonathan, Alex, and all the colleagues here, Boris and Taylor. So thank you so much for that. The other point we just wanted to mention that, we and we probably am repeating what Jonathan is saying, but this is very important. We know that there is a 31st March milestone, but we should take this as a beginning of the journey in terms of the reporting, because 30th of September is also a milestone for the same reporting year 2020. So the 2020 reporting doesn't end with the 31st March. And also, we will be able to, even with the SDG reporting, because many countries have that in mind, that are we being able to update SDG reporting, we will be able to update SDG reporting as the numbers come in. So really, as Jonathan said, we will work together towards helping and improving the data or the guidance that we have given now through the working paper, and also going forward on the other indicators. So we do understand the need and the pressure for the 31st March milestone, but let's also look at the next one on the 30th September. And also really want to acknowledge my colleagues from the regional offices who have joined us, like from WHO. We have also from UNDRR, Jennifer, and Mirna and others who have joined, and many others joined in the morning. So we really, as same to echo, just like the regional offices and the country offices of WHO are really very, engaged on this process. From our side also, we have the full commitment from our regional offices. In fact, we've already got requests from Jennifer that, oh, can we start, translating this into Spanish? And then this is great. And we're also, I'm sure Mirna will do that for Arabic as well, Arabic and French. So yes, we will like to have these translations done so that, you can reach out a lot because the whole, by the way, just the SFM system is available in all 6 languages. Everything is on all 6 languages, and hence the information is also pretty high. And that is why currently over 140 countries are already providing data. So you can see the reach. So I'll stop here, but thank you so much again. And Jonathan, I return the floor to you. And thanks again from our personal and from our UNDRR side. Cheers.
Sorry. Thanks very much, Rahul. I see that Professor Virginia Murray from Public Health England has got her hand up. Virginia, a quick comment, please, and then we will close the session. Over to you, Virginia. Please unmute.
I have unmuted, and I just wanted to say huge thanks, Jonathan and Rahul, for the incredible presentation of this work. COVID-19 has really caused us a great deal of anxiety, making sure that we report adequately. We have been trying very hard to support all Boris's work, and we've been sending in vast quantities of data. What I really wanted to say was that we will try and test this with our UK focal point for the Sendai Framework Monitor to see how it works, and we'll come back with comments. But I just wondered, Rahul, I was a bit worried, aren't we going to get our UNDRR International Science Council Hazard Definition and Classification Technical Report hazard list into the framework, into the monitor, so that we can make sure it's as complete as possible? Your advice would be so welcome. And thank you very much for this opportunity to hear this amazing work and to be part of the people who are really interested in how it's going to work. Over.
Okay, Rahul, just a quick quick response to that question from Professor Murray, and thanks very much, Virginia, for your encouragement and with regard to this work. Thank you. Rahul, quick comment, please.
Yes, we are working on that, and the hazard list, as you could see in our colleague Mira's presentation. We mentioned that there's already this International Science Council's work, which has more than 88 biological hazards there. So yes, we will be definitely looking at that as one of the guiding principles, and this is already, we have incorporated them in our trainings as well. So yeah, we are moving towards that. Absolutely. Thank you.
Okay, well, thank you very much. We're bringing this to a close. I'd like to invite colleague Dr. Kutsia Huda if she would like to say any final remarks. Over to you, Kutsia.
Thank you, Jonathan. Because of the network issue, I think that I won't be able to turn on the video, then my call will drop off. So now I would like to seize this opportunity to thank everyone, particularly my colleagues from UNDRR side and WHO side who actually put together this session, and also the regional colleagues, country offices colleagues, for their active and engaged participations from both ends, UNDRR and WHO. I would also like to thank some of our partners who joined to this session, and also would like to reiterate one thing, that the purpose of this whole session is that to create this interface between two agencies, Sendai Focal Point and also health sector, so that health data are well collected and well reported. And then we can actually highlight the specificities of these health emergencies, and then report actually captures that how this health situation and health capacities are being used to reduce the disaster risk in the countries. I just wish and hope that the spirit of this webinar will actually replicate in the countries while collecting the data, the health data for the Sendai monitoring, in terms of creating that interface in the country level between the Sendai focal person and also the health sector, Ministry of Health and other health partners, including WHO. And I would also like to reiterate another thing, that yes, the deadlines are there, and then it's important to go by the deadlines, because this, what we are doing today, is not doing it for only this year. We would like to establish a system so that we can take forward the system, that system should be as robust, to take it forward to report for the next 9 years till the Sendai ends. And I'm sure that as the Sendai evolve from Hyogo, there will be some other mechanism that will evolve from Sendai to take forward this disaster reduction agenda in the coming days. Because without this disaster risk reduction, the saving the planet wouldn't be possible, saving the population wouldn't be possible as well. And this is the only way to make sure and protect the sustainable development goal in the countries. Back to you, Jonathan. Thank you. I thank my team, Liara team, Jonathan, Taylor, Jazz, Rakesh, all others for putting together this session so efficiently. Thank you, and back to you, Jonathan.
Thank you very much, Kutsir, and really re-emphasizing those points about this engagement, not just for now, but in the medium and longer term. We are focused, admittedly, in this session on the reporting, but ultimately we're also about ensuring that our communities and countries are safer and healthier in the future. And let's see how this reporting can also contribute to those efforts. I'd like to reinforce the point that all of the information that's been shared with you today will be made available to you. We'll go through the appropriate channels, and we'll also come back to you with the next steps in this process, including a proposal to hold a session next week, as I said, most likely on Thursday, and we would welcome your participation in that particular session. Moreover, we encourage you to engage with your counterparts, whether you're in the Ministry of Health or a Sendai Framework Coordinating Institution. Perhaps you're well advanced in your dialogue. Perhaps that's just starting. But please reach out to each other and use the working paper as a medium in which to take this forward. I'd like to thank everybody for participating in this particular session, to all the panelists, to all these resource people, to all the participants, and also for our colleagues who have been behind the scenes on the technical side. And with that, I'd close this particular session, and we look forward to our next interaction. Thank you very much.